All righty, let's see if we can get this show on the road. We'll get everyone out of the waiting room here into the session with us. Always takes just a moment to get everyone here. Hope you're having a fabulous day. I'm excited to talk to you today about multiple choice question strategies. We've got a bunch of practice questions I'd like to get to. We'll see how many we have time for. I do anticipate that today's session will go somewhere between 60 and 90 minutes. It's kind of depending on what questions you have and what you'd like to talk about. Certainly lots of good stuff to talk about with regard to not only how to answer the content of a question, but also to dissect out what I like to call X-ray vision when it comes to practice questions, making sure that you can identify clearly what it is that's being asked of you. And so you can then therefore put down your very, very best answer. So with that, we'll go ahead and get started for today. The notes for today, you can find them. I think I've got them posted here in the chat box. Be sure to head over to that chat box. You can find the session notes if you'd like to take note. Also of note, those of you who are part of the VIP class already, I will post my annotated version of the slides as well. So you'll get the original version plus the annotated version. And then the recording of today's session, I will be posting this to our VIP course page. Be sure to check that out if you'd like to check out the recording of today's multiple choice question strategies. So as we get started today, I would encourage, if you do have questions for me, use the Q&A feature in Zoom. You can go over to the Q&A box and it queues up your questions so that I can see them. And I want to make sure to get to as many of those as we possibly can today. Again, the goal is to go over a bunch of practice questions. If we have time, we'll go through the NPTE demo exam. It'll show you some video questions as well, kind of the format of what you'd expect on test day. If we have time, we'll go through a couple of those as well. So without further ado, let's go ahead and get started. Those of you who weren't here on Tuesday, my name is Will. I'm the founder of PT Final Exam. I've been a PT now for 12 years this spring. I'll be 12 years, and I currently continue to practice as a PT. So not only do I get to have the fun over here at PT Final Exam, but I also have the fun of doing some documentation, patient care, working with a physical therapist assistant. All of that, I get to not just talk the talk, but walk the walk. I guess it's because that's why I got into PTs, because I enjoyed being with patients. I enjoyed helping them to overcome their illnesses and injuries. I've got one patient with a pretty significant femoral nerve injury that we're working through. Like, there's lots of interesting cases, and I find that it translates very well into PT Final Exam. So the goal for today, we'll be talking about multiple choice question strategies, how to dissect out the practice questions so that you can clearly see what it is that they're asking. And then we will do a bunch of questions together today. And so as we do those, I will be asking for your participation. Be sure to have your computer, your phone queued up so you can see the question and then select your answer, and then we'll talk about it together. Just a quick plug again for the NPT podcast. So this is something I've had requests in the past to increase the number of podcast episodes that I do on a regular basis. And so that is currently what's happening. You'll note that those of you who've been listening for a while, there are more episodes available now than there were previously. We have several 100,000 downloads. I mean, really, we're really just picking up the pace when it comes to the NPT podcast. If you haven't already, please head over there. You can subscribe to it as well as leave us a review. It'd be much appreciated as we try to get through the podcast algorithms and get the word out. So much appreciated there. And then those of you, I talked about this a bunch on Tuesday, so I won't belabor the point, but there are a bunch of you who are already signed up for our VIPT class. If you haven't already, I'd highly encourage that you consider it. I know we have a few guests here today. The VIPT class, this is the one where really the rubber hits the road. We talk about content, practice questions, loads and loads of video content. Plus, you get an opportunity to work with me in a small group setting, plus in a one-on-one setting. It really is the best bang for your buck when it comes to, I mean, really just the sheer number of hours of content plus the organization. You'll find that it is unmatched. So I'd highly encourage you to check that out, the VIPT class. If you do have any questions about that, you can email me directly, will@ptfinalexam.com, and you can check that out as well as, and I didn't mention this last time, but if you get a group of 5 or more students to sign up together from your cohort, we can reduce the price as well. So if you've got a group of students who are signing up for our group discount, you can certainly sign up as a group, and we'd be very happy to have you. Question comes across the chat box. If there is a slide deck, yes, you can download that directly from the Dropbox link I just posted in the chat box. Those of you watching the recording afterward, I'll make sure to include the slide deck here with the video recording as well. So, all right, let's see. There's a question. Ben says, do you have a review program that is modular? So a pre-recorded review program? Yes. So we do have an independent study course that is a pre-recorded version of a previous VIP class. It doesn't have as much content as our current VIP class, but it is an excellent at your own pace modular approach where you can go through non-systems, integumentary, lymphatic system, and then through the entirety of the FSBPT content outline. So that certainly is available. The more self-paced independent study course. All right, so let's talk about some practice questions or question strategies. So as you know, on the NPTE, you get multiple choice questions. Multiple choice questions, love them or hate them, that's what you've got to prepare for on test day. I know there are a lot of you who did not have lots of multiple choice questions in school, maybe more story-based or case-based questions. I know there's a lot of you who did have lots of them throughout school. And so this is something that, again, not reinventing what practice questions or what multiple choice questions are, but helping you just to see what it is when it comes to answering them properly and understanding how they were written. And that, it really goes a long way. So number one, start with a positive attitude. So this is that positive feedback loop that as you have a better attitude, you tend to be more focused and you have a better attitude because you performed well, and it leads up and up. The opposite would be a negative attitude leading to poor performance, and it spirals downward. So again, this is an example of a positive feedback loop. My high recommendation here is that you begin each question with the thought that you can find the answer to this. So whether it's a difficult question or not, you've been trained, you've been tested time and time again, 3 years of PT school, like there is an answer and you can find it. And that is a good first step when it comes to multiple choice questions. So my method for answering questions, this is one, we'll call it a very boring way of answering questions, perhaps not very sexy in a lot of ways. However, it works for me. You may have a different method. I know there's some people who propose that you read them backwards, forwards, whatever it is. This is just a very straightforward, logical way. And I've found that as you're answering questions, you have to be precise in your practice so that it becomes routine to you on test day. Because on test day in a high stress environment, your brain tends to, at least in my case, I get scatterbrained. I feel like my eyes are just bouncing across the page. I'm not seeing it. And this is where practice comes in. So it's not just the quantity of practice, but the quality of practice. So practice this logical sequence. So number one, you read the questions, get an idea of what it is that it's even looking for. Most of the time with this general idea, you can have, again, what I call the X-ray vision. So the X-ray vision is just where you can see, oh, this is a question testing me on electrolyte values, or this is a question testing me on ST segment changes. Do I know anything about that? Okay, so general idea. Second one, you're looking for the key information. This is where you can use your cursor and just kind of highlight the material. Find the key words that are the most important. So if you have patient age, you have duration of symptoms, aggravating factors, like try to find the key information. And then finally, the last reading of the question, these are all very quick readings. Don't get me wrong. You're not spending like 15 minutes on each question, but look at the question one more time, just to make sure you're looking at the correct modifier of the word: best, worst, most, least, so that you're answering the right question with the right answer. How many of you have answered the right answer to the wrong question before? And that's so frustrating when it says least and you read it as most, or most is least. I remember in PT school, I had one experience where I totally misread the question. And I was so frustrated because I knew the content, but my professor, she didn't have any mercy on me. She said, well, whether you know the content or not, you answered the question wrong. It's like, so don't do that on test day. Then finally, after you've read the question, this is where, so after those first 3 readings of the question, then you formulate an answer in your mind. You try to get the characteristics of the answer in your mind. So then as you read through the answer options, you're able to either rule in or rule them out based on your reading of the question. So this is one where even if you don't know the exact answer, formulate the characteristics of the answer. The characteristics would be this, or there'd be a safety concern here, or whatever it is. Try to formulate an answer in your mind, look through each option sequentially, and then finally rule them in, rule them out, trying to find the correct answer. And so very often what people do is they will score the items. So in a sense, they're Think of it this way. You've got 4 items in front of you. Find or put a subjective score beside them. Say, all right, this has got 1 point. This got 2 points. This has 3 points. This has 1 point. Try to compare them in that style, almost like a basketball game, like which team is winning. And anyway, just another way to look at that. So here's the anatomy of a multiple choice question. This is an actual sample question off of the FSBPT's website. So we'll just go through this together. After sitting at a computer station for 2 to 3 hours, an individual reports experiencing sharp localized pain in the left arm. When asked to show the location of the pain, the individual points to the area of the insertion of the deltoid. The pain disappears when the individual stands up and walks around briefly. Which of the following interventions will most likely solve the problem, or is most likely to correct the problem? All right, so in the scenario, we see some key information. We see that we've got sitting for a prolonged period of time. They get sharp localized pain. Anytime you see sharp localized pain, you start to think of somatic type pain. So somatic pain means that it's your classic musculoskeletal pain. So sharp and localized. And then we see that the pain actually solves itself or resolves in the question. When asked to show the location of the pain, points to the insertion area of the deltoid, pain disappears. So that's maybe the most important part of this whole question. The pain disappears when the individual stands up and walks around briefly. And so then the final reading, which of the following interventions is most likely? So we need to most likely correct the problem. So then we go sequentially through each item. Isometric strengthening of the deltoid. Well, this is not a weakness issue. I don't see anything here that describes weakness. I mean, possibly posture, but the deltoid really wouldn't have a lot to do there. Lumbar extension exercise in prone, again, seems unrelated if we're talking about cervical region, shoulder region. Instruction in correct postural alignment in sitting. So we see that has all the characteristics we're looking for. This is actually the correct answer. And then finally, the last one, instruction in shoulder active range of motion. When would you do active range of motion exercises? Well, usually when they've graduated from passive range of motion to active assisted range of motion to active range of motion, again, that's a strengthening / range of motion protocol. And we don't see anything here that's indicating significant weakness. Rather, we see a postural issue that can be corrected by standing up and walking around. So therefore, we want to get better posture while sitting at the computer station. So there you go. That's just an example, the anatomy of the multiple choice question. So this just lists it out. We talked about all this, but watch carefully in the scenario for relevant information. When they write these questions, they have to be brief. They can't be lengthy questions. So they won't put long tangents in there. Rather, the content contained in the question must be relevant, or at least relevant enough to help you make a decision, yes or no, on the correct answer. Now, granted, there may be some things that we'll call them misleading, things that could lead you down a different pathway, but exclusively speaking, the test questions must be clear and they must contain adequate information to answer them. The STEM, that's just the actual question, and I guess I just want to point out, the sentence usually is structured like this: which of the following interventions? This is always a noun, almost always a noun. So make sure that your answer is an intervention, or which of the following special tests, or which of the following nerves. Just make sure that you are matching correctly the noun with your selected answer. All right, we'll go through this one together. A patient has used crutches with partial weight bearing toe touch gait for the past 3 months. When progressed to full weight bearing, the patient is unable to demonstrate a heel toe gait sequence with the involved extremity. Which of the following disorders is the most likely origin of the gait abnormality? So that's our first reading. The second reading, looking for key information. We see crutches, partial weight bearing, toe touch gait, maybe is the biggest thing here, for 3 months. When progressed to full weight bearing, the patient is unable to demonstrate a heel toe gait sequence with the involved extremity. Which of the following disorders is most likely origin of the gait abnormality? All right, so, and then just the final reading is disorder, most likely. So we're trying to find the most likely thing to have caused the toe heel gait pattern instead of the heel toe. So plantar fasciitis, what are the characteristics of plantar fasciitis? Well, almost always plantar fasciitis is described as painful with the first 2 steps in the morning. Then it resolves somewhat as the plantar fascia loosens up. And so we don't really see anything here. Not a great option. Fibular or peroneal nerve palsy. So as you recall, the peroneal nerve branches into superficial and deep peroneal, leading to significant weakness. But again, we don't see anything that would indicate that we had a nerve injury, significant weakness, possibly. I mean, not great. You could kind of make an argument for deep peroneal nerve just because it does innervate the dorsiflexors, but again, there's nothing to remember. This isn't the deep peroneal nerve. This is the common or full peroneal nerve, meaning that we'd have weakness of dorsiflexors plus everters of the foot. Again, we don't see a lot of that here. Heel cord tightness. Now, this does fit nicely with the prolonged immobilization, crutches, partial weight bearing, toe touch gait for 3 months. So this person has used toe touch gait for 3 months. So a prolonged period of time, it is very likely they have developed tightness. And then finally, hammer toe. This one I would feel like is an outlier here. It's not going to affect your heel toe sequence unless it was painful, but even then you'd probably stay off your toe, just having the disorder down into the foot. So we see that pretty clearly the heel cord tightness is the most likely answer here. Heel cord tightness is the most likely answer. All right, so this is just a little practice we've done together. Now I'll be pushing you to make your selections. So again, just a reminder, as you go through the questions, make sure that you are selecting an answer that fits all of the data in the question. So make sure that in your mental checklist that everything is accounted for in your selected answer option, because so often what they'll do is they'll put an answer that is partially correct, meaning that it has some possible maybe connection. Don't go for maybe connections, go for full connections here. You just want to make sure that every bit of data is accounted for in your answer option. And just if an answer is partially incorrect, then it's totally incorrect. Again, trying to make mental notes to score options against each other. Now, when it does come to image or video questions, this is the only time that I would recommend that you do it a little bit backwards, meaning that you look at the answer options first. So read the question and answer options first, and then evaluate the image. What that does is it narrows down your focus so you can see what it is you're looking for in the image. So in this case, we see what's called a Hill-Sachs lesion in the humeral head. This is usually after an anterior dislocation. And so what you'd look for in the answer options would say, what lesion is present, or what mechanism of injury is most likely to have caused the lesion that's present, that's indicated by the arrow in the image. And so as you look at that, you say, okay, that's a Hill-Sachs lesion. I'll give this as a quiz question. What injury is most likely to result in a Hill-Sachs lesion? What injury, so just a little quiz off the top of your head, what injury is most likely to result in a Hill-Sachs lesion? Give you a moment to chew on that one. What injury is most likely to result in a Hill-Sachs lesion? So as you recall, the Hill-Sachs lesion is a dent in the humeral head. That dent in the humeral head is usually from a traumatic dislocation where you've had the shoulder almost always anterior. So dislocation, it pops out and bangs up against the acromion, creating a big dent. And so therefore you get this almost always from an anterior dislocation, the Hill-Sachs lesion, which unfortunately usually coincides with some type of labral tear, whether that's a superior labral tear or a Bankart lesion, meaning a lower labral tear. So almost always labrum tear plus Hill-Sachs lesion. And just, if I can spell it right, Hill-Sachs lesion is what's being shown in this image. So there you go. This is the only time when I would suggest that you read a question backwards, looking at the answer options first, before then thoroughly evaluating the image. And this would be the same for the video questions as well. All right, so other things to note, make sure you're putting down your very best guess. There's no penalty for guessing. So let's say you have no idea what the question is about. This is one where you would identify your first choice, try to find what feels best, because very often subconsciously you'll be directed towards something that feels better than others. But what if you really just don't know the answer to the question? And this is the $64 question. Let me tell you, I get asked this time and time again, like, Will, I can narrow it down to 50-50, but I can never identify the correct answer. And really it boils down to a couple things. Number one, either there's content in the stem of the question that is not immediately apparent, or maybe that you haven't made the connection with. Or number two is that the content is less known to you, that you don't have as much mastery as you wish you had on that content. I mean, how many times does this happen on the test? You'll get to a question, you're like, oh, I've seen this, but I can't remember it. So here are some tips in the case you can narrow it down to 50-50, or in the case you don't even know the answer. Try to identify what body system is being tested. So try to narrow it down. Say, okay, like in the question that asked about sharp localized pain, okay, that sounds musculoskeletal. I need to find something that is musculoskeletal based. Try to then identify what it's asking: examination, differential diagnosis, intervention. This is one, just a little tip here. Pay very close attention to the lengthiest answer option, just because very often it contains the most information, is the most qualified. It doesn't always work this way, but again, this is for a total guess. Look at the answer option that is the lengthiest or contains the most information. At least take a second look at that. Eliminate any outliers, like in that case of hammer toe, you can eliminate that. And chances are you can narrow it down to 50-50. And then again, it comes back to go with your gut. Make your very best guess. Another way to think of it is, what would the most reasonable therapist that ever existed, what would the most reasonable of reasonable therapists do in this case? Or another way to look at it is, what would the textbook say? And again, you kind of pull yourself out of yourself, so that you're looking at it from the 10,000 foot view and say, well, what would the book say is the safest, most effective pathway here? And very often that leads you to, okay, this one appears to be safer. This one appears to be the next step to do. I mean, there's a couple of ways to shake it, but again, look at it from the 10,000 foot view. And this is where you think of it this way. So if you're staring at that question, what would happen if I walked into the room and I said, that would be quite the apparition if I walked in the room. If I called you on the phone and said, hey, you're looking at this question, let me just ask you, what would your therapy professors say is the correct answer here? And like, well, so-and-so, they would probably say that this one looks better than the others, or whatever. You're just pulling yourself out of the situation so you can look at it even more analytically. There is a very nasty question I saw, let's see, a practice question not too long ago. It was essentially, I'm trying to remember the exact context of it, but the gist of the question was a person with a rotator cuff tear. And I think I've got one. No, I'm thinking of my own question here. There's another question I saw. It was a different question, different scenario, but just go with me here. If a patient has a rotator cuff tear and they come in for your therapy evaluation, what is the next most important step to do? And it'll list like Codman pendulum exercises. And that's a great exercise, or gripping exercise to reduce edema. But one of the answer options is an examination technique to observe, or not even exam, think about like history or review of systems. Ask the patient about the mechanism of injury and prior level of function. That type of a thing brings you to the more proximal thing. The nearest thing you need to do first in your exam is get a good idea of how this all started. What's the mechanism? Get more information. Then you proceed into your physical exam. And only after that's complete, then you continue on to your intervention. So another little trick on questions is that very often they will ask about what's the most appropriate next step. Well, chances are that they don't want you to always be calling 911 or calling the doctor. I mean, yes, there are cases where you will call 911 or call the doctor, but they want to know what other information will help you make decisions. Another classic example I like to ask students is, so let's say you had a patient come into your clinic, a 65-year-old male comes in, sits down in the chair, getting his vital signs, and he's holding his chest, and he says, my chest is killing me. What would you do next? Like, well, obviously one of the options is to call 911, but the more appropriate option is to get a good idea of what the instigating or the aggravating factors are, If he said, yeah, I just had a super spicy meal over at Chili's, I had the baby back ribs, extra spicy, and I get heartburn every time I eat a spicy meal. Like, okay, that takes it from emergency 911 to now, okay, now we just have to consider whether it hurts too bad to, like, would exercise exacerbate it? Probably hold off on exercises that day just because he's so symptomatic. However, if he said instead, yeah, I got my chest pain walking up the stairs here, but it seems to be dissipating now. You're like, okay, that sounds a lot like stable angina pectoris or stable chest pain. Like, all right, have you been evaluated for that before? Oh yeah, I get it all the time. I take nitro every time it's bad. All right, maybe just a call to the doctor in that case, just to report and see what they want to do. Versus a third scenario, comes in, he's got chest pain, and he says, yeah, I've got this gripping chest pain. I've had it since this morning, hasn't gone away a bit. Like, all right, that starts to sound like unstable angina pectoris, which would lead to a 911 call. So you can see how getting more information is very often what they'll test you on, because then it dictates what you would do next. This is the ever present. I was just talking with one of you not too long ago about the ever present. It depends. It depends mostly because the situation and scenario can be quite vastly different. All right. Clearly on the list of things you need to know, you need to have the content, have significant, I would say, yeah, more than significant. You need to have content mastery. You need to have content mastery of the key content. And that's what we go over in the class. We go over lots and lots and lots of content. Again, you've got to put it in a way that sticks in your mind for your long-term memory banks, not just recognition. You need to be able to problem solve now with content. A good example of this, back to heart attacks, is, do you know what the signs and symptoms are for angina pectoris? Do you know what they look like in a female patient? Do you know what they look like for your non-typical patient? Like, this is more than just recognition. This is now problem solving for different cases. And that's, again, what they love to test you on testing. All right, other things, we've talked about most of this stuff. Put your best guess. There's no penalty for guessing. There's no pattern. So it's all randomized. So don't worry about if you get like 3 A's in a row or 7 A's in a row. Even if you get 250 A's in a row, then maybe worry about that. But don't look for patterns. It's just they randomize the answer options. Try to eliminate as many answer options as you can. So if you can eliminate 3, then the final answer must be correct. And then this is a big one. Don't change your answer unless you need to. Don't change your answer, because very often you will have gone with your gut intuition, your first premonition is almost always on the right path to being correct, just because of that subconscious content recognition that you have. So just, yeah, make sure that you have put down your best answer, and then don't change it unless you need to, unless you just like totally misread the question. You're like, oh, they said least instead of most. All right, I better get the correct answer down. All right, a couple little tips here for those of you who are fast test takers. So I had this question, when was it? A couple of quarters ago. I had a student who said, yeah, will every practice test I finish in like an hour and a half? I'm just done. I'm a fast test taker. Do I need to put the brakes on and slow way down and take the full 5 hours for my test? And the answer is maybe. So generally speaking, you want to stick with the pace that you are accustomed to. You've taken lots of exams in the past. You know yourself very well. So there is the potential that you could read too quickly and accidentally overlook material, certainly. However, there is a big advantage to being quick, is that you don't get as fatigued. I mean, granted, you'll still have plenty of fatigue, but those of you, I know there's some of you here who take the exam with either time and a half or double time with test accommodations. And I'll bet you dollars to donuts that you tell me that after you get out of a 10-hour exam, you feel quite fatigued just because you've been there all day. So there is an advantage that it does bring less fatigue. However, the trouble is that you could be going too quickly. So thread the needle there. You don't want to totally reinvent the way you take tests for this test. You want to stick with what has worked for you in the past. Just stick to your normal pacing. I know that I tend to finish, I'm trying to remember. I finished the test with like, I think, an hour and a half left over. And I checked answers. I'd gone sequentially through everything. And I did not quite have a perfect score. I was close to it. I was just a couple of questions off the perfect score. I wish I'd taken my own class. Then I would have had the perfect score. But the point being that as you take the questions, you go sequentially through them, be very analytical and thoughtful as you do it, and then you complete the test. You don't need to belabor it. Those of you who are slow test takers, you've got to pick up the pace. You've only got 5 hours, which equates to about 1 hour per section. Highly, highly recommend you watch that clock and do a half section every half hour. So we're talking 25 questions every half hour. You've got to beat that pace in order to have enough time to finish the exam. And so then how do you do that? Well, you practice the test, practice taking the test, and practice tests in test taking scenarios. And the idea is that you should take a practice test about every 1 to 2 weeks. Now, the reason I say 1 to 2 weeks, so you can have ample time to dissect it, make sure you understand the content they're on, and then make sure you take your last practice test about 5 to 10 days before the exam. You don't want to be taking a full exam like 2 days before the test. It'll stress you out. You won't have enough time to go through it adequately. So time your practice tests to use the ones you have available to you every 1 to 2 weeks, and then finish up on full exams about a week before test day. And then from there on, that last week, you can take small quizzes of exams, like 20 questions or 50 questions at a time. Try to take it in small bite-sized chunks so that you can not get too stressed out or tired, but still be encountering practice questions. All right, so there's a question. Hi, is this going to be the same strategy for the upcoming change in the curriculum and the way they're going to be doing the setting? They're going to be setting the questions for 2024. It will be essentially the same. So for 2024, those of you who are testing in 2023, I want you to just close your ears for a minute. This does not apply to you. Those of you testing in 2024 down the road, they have reduced the quantity of questions by a handful, but they've increased, or they'll be creating what they call scenario-based questions, where you'll have a patient scenario that's like a paragraph long, and then you'll answer 3 questions based on that. They are assuming that it will take, and rightly so, that it will take more time to read through a larger patient case. So therefore, they're reducing the number of questions you have to do because they anticipate taking more time. It will still be the same total quantity of time. You'll have 5 hours to take the test. There will just be fewer questions and more reading associated with it. So the strategy still applies, that you don't want to read too quickly. You don't want to go too slowly. You want to make sure you're at your good average pace. So there'll be video questions and scenario questions. Again, you'll be targeting about 1 section per hour and about a half section every half hour. Even with the differing question format, it will, if I'm not mistaken, you'll see this on the practice Pete's, and they haven't entirely disclosed everything about it yet. But if I'm not mistaken, it'll be at the end of each section, you'll have like 2 cases that you'll have to evaluate with multiple questions for each case. So you go through a handful of cases at the end of each section, and then you'll move on to the next section, and you'll still have the 5 sections. Maria asks, how much time per question do you think is suitable? Well, the average time has to be 72 seconds. So 72 seconds, if you just do the math, for the entirety of the exam, 5 hours, 250 items, you'll have 72 seconds per item, meaning just a little bit more than a minute. So during your practice, you should practice averaging a minute or slightly more per question, so you have a little bit of leeway. You don't want to push right to like 71.5 seconds average, because then you'll be rushed for time at the end. You'll feel stressed. So try to push it just a little bit, so you're averaging about a question a minute, and make sure that you finish 50 questions in an hour. So 72 seconds. All right, let's do some practice questions. So, and just remember, as you're doing these practice questions, you can chime in with what questions you have for me. So go to the Q&A box, and you can type in those questions, and I'll make sure to get to them as much as I can. So here in front of you, you see a practice question. I'll be quiet while you answer this for 72 seconds. So again, give you about a minute. Please select your answer, and we'll talk about it. So ready, set, and go. All right, just a few more moments. All right, and time. So this one, when compared to upper extremity exercise test results, lower extremity exercise typically results in what? So this is a comparison question, comparing the upper extremity exercise to the lower extremity exercise. You would expect that for the lower extremity, you would have a lesser heart rate response, a lesser blood pressure response, but increased maximal oxygen uptake. Another way to think of it is VO2 max is another way to think of maximal oxygen uptake. So, but as an example of this, I ask people to consider, all right, so let's say you had to run a mile on your legs, just a regular run a mile, versus running a mile on your hands. Running a mile on your hands, your upper extremities would be more stressful to your system because less mechanical advantage, smaller muscle mass, more type 2 muscle fibers. You'd find that you'd have a greater sympathetic response with the upper extremities as compared to the lower extremities. Now, one of the reasons I really like this question that I built for you is because I can almost guarantee this is going to show up on the test in one form or fashion. It'll be a comparison between upper and lower extremities. They could very easily, and this is a great example of learning the content backward and forward. So this is that problem solving. If I were to reverse the comparison when compared to the lower extremity, upper extremity exercise will result in what? Well, upper extremity will result in a greater response. Lower extremity results in a lesser response. It's not that there's no response. It's just that it's much more stressful to do arm exercise than it is to do leg exercise. That's again related to muscle mass, mechanical advantage, and the type of muscle fibers. In the upper extremity, we typically have type 2 muscle fiber, lots more type 2 fast twitch. Whereas with lower extremity, we get type 1 slow twitch, lots of mitochondria. They're able to uptake the oxygen more easily, and you can run a marathon on your legs. Be more difficult with your arms. And this is clinically important because during exercise, especially after someone who's had a cardiac episode, you want to be very cautious about putting them on isolated upper extremity exercise because of the stress on the system. Excellent. So let's go on to our next question here. What I'll do is I'll queue up the next question. Give you about a minute on this one. I'll be quiet while you answer. Ready, set, and go. All right, just a few more moments. All right, and time. So this question asking about the tibial nerve, patient who has suffered a traumatic blow to the posterior knee begins to exhibit signs of tibial nerve dysfunction. Which of the following impairments will most likely be present with a tibial nerve injury at the level of the popliteal fossa? So kind of a two-step question. You have to know what in the world the tibial nerve is and what it innervates, and then take that and translate it to impairments that could show up. And so tibial nerve dysfunction, we know the tibial nerve innervates the posterior compartment. Posterior compartment, talking about the plantar flexors, gastroc soleus, and then it branches down into the plantar nerves, which hits the plantar surface of the foot. You've got medial and lateral plantar nerves, everything on the plantar surface. The dorsiflexors are innervated by the deep peroneal nerve, and then the sensation on the dorsal surface of the foot, that is innervated by the superficial peroneal nerve. So the peroneal nerve would be involved in dorsiflexion, eversion, and then sensation on the dorsal surface of the foot, whereas the plantar surface would be affected by the tibial nerve. tubular. Good. All right, next question here. And I see a question over in the Q&A box. I'm going to hold on that. It's a question about what course to recommend for a multiple attempt. We'll talk about that here in a minute. So let's go ahead and hit another content question. I'll be quiet while you answer. Ready, set, and go. All right, just another few moments. All right, and time. A patient is noted to have limited great toe extension during the terminal stance phase of gait. I could have made this question even more challenging by just describing limitations in the great toe during the terminal stance phase of gait, which we know you require about 60 degrees of extension of the great toe or the hallux during terminal stance, just before, as the heel off, just before toe off. In order to increase the first MTP joint extension, which joint mobilization would be most appropriate? So this is applying the convex concave rule. So as you recall, that first MTP joint is a concavity moving on a convexity. So therefore you glide in the same direction. So a dorsal glide, gliding the proximal phalanx dorsally, that'll improve great toe extension. So if I were to, in this image, this is our first MTP joint. You see that it's a concavity. We apply the concave rule. And so therefore we have to glide in the same direction as the roll. Just if I were to draw it out from a side view, you'd see this, the first MTP joint. And the interphalangeal joint. And so as you move into great toe extension, you're rolling towards the dorsal surface, requiring a dorsal glide or glide in the same direction. Now, those of you who, if you're like me, you're like, how can I remember the foot and the hand? The nice part is the foot and the hand are identical, meaning that if you make a nice fist and look at your metacarpal heads, so you see your knuckles, you'll see that they are concave. And so your fingers moving on the metacarpal head is concave, moving on the convex metacarpal head. So we apply the concave rule for the fingers. The nice part is it applies to the toes too. So the toes and the fingers follow the same rule. So my little quick way to remember this, make a nice fist, and you'll see those metacarpal heads and be like, okay, that makes sense. Metacarpal heads are convex, so therefore the phalanges are concave, and so therefore we glide in the same direction. So during the VIP class, we go through each of the joints. We go through all the major joints and talk about convex concave rule. We talk about open chain and even some closed kinetic chain. That's a lot of fun to go through each of the joints and make sure that you can visualize what's necessary and then what glide would be helpful. That's something that I've found it always shows up on test questions. All right, next question here. Give you about a minute on this. Relaunch, ready, set, and go. Right, just a few more moments. Right, and time. So this one, You have to analyze a table of data. Sometimes you'll see questions that are formulated in this way. The patient presents physical therapy with weakness affecting the right upper extremity. Manual muscle testing reveals the following results. All right, so we see FPL, the flexors on the thumb side. So we see weakness here, weakness of the pronator teres, pronator quadratus, and then the lateral two lumbricals. So anatomical position, lateral two lumbricals are on the thumb side. So the first and second lumbricals are on the thumb side. So we see lots of problems on the thumb side or radial side. And then the medial two lumbricals, that's the ulnar side. And then the extensor digitorum innervated by the radial nerve. So we got the ulnar nerve, the radial nerve. And so that leaves us only with the median nerve. The median nerve is what innervates all of these guys. So my funny little way to remember this, a lot of you have heard me say this before, but half loaf of pumpernickel. Any of you had some of those ancient grains? Pumpernickel is a dark colored bread. And anyway, not that I love pumpernickel bread, but it's a fun word to say, pumpernickel. So the first and second lumbricals, the opponens pollicis, abductor pollicis brevis, all the flexors on the thumb side, on the radial side, or the thumb side, and then both pronators. So that's the half loaf of pumpernickel. That's what the median nerve innervates. And so most likely, damage to the median nerve could come from really anywhere. But if it was just isolated to the hand, then that would be like a median, or not a median, it would be a carpal tunnel issue. However, you can have issues anywhere up the median nerve, especially if you had like a supracondylar fracture of the humerus. You can get it there. So there's a couple of things that can damage the median nerve. Other things here, posterior interosseous nerve. This is an extensor. It's a branch of the radial nerve, so it hits all the extensors with almost no sensory. I think there's a tiny bit of proprioceptive sensory at the wrist, but pretty much everything that has extensors, extensor carpi radialis brevis, extensor digitorum, extensor pollicis longus, extensor pollicis brevis, all the extensors. The posterior interosseous nerve is a branch of radial. The radial nerve, obviously, very correlated with the posterior interosseous nerve. It's the main nerve and it innervates the pretty much everything extensor except for brachioradialis. The nice part here is that the word radial appears in brachioradialis, so that you know it's innervated by the radial nerve. And then finally, the ulnar nerve hits everything on the ulnar side, flexors on the ulnar side, and then a lot of the intrinsics. But especially, this is the one you've got to remember, is adductor pollicis. So adductor pollicis is what adducts the thumb as you think about. So if you were to give me a high five on the screen, that's extension and flexion. So ab and adduction, the adductor pollicis is what adducts the thumb. Good. Jonathan says, is the supinator muscle innervated by the radial nerve? Yes, the supinator is innervated by the radial nerve. Did I not list it here? I didn't list it here, but yeah, the supinator is part of the radial nerve as well. And that's one where during class, we'll talk about my fun little acronyms for all these, but yeah, great ways to remember all these. You can also check out over on YouTube, youtube.com/PT final exam. I just posted some little short videos about the acronyms for these upper extremity nerves that I think you'll really like as well. All right. Okay, so next question. We've got a few minutes here. Let's go through another question. All right, this is a good one. You like this one. All right, give you about a minute. Ready, set, and go. All right, just a few more moments. A few more moments. All right, and time. So this one, I wanted to make sure to include this one because this is a reading, an especially important question for your reading skills. A therapist is treating a patient with a suspected tibiofibular ligament tear. Which of the following special tests will most likely confirm the diagnosis? So by raise of hands, how many of you, when you saw the word tibiofibular, replaced it in your mind with the word talofibular? Just by raise of hands, how many of you saw talofibular instead of tibiofibular? So if you're like me, that's precisely what I did the first time I saw a question that involved the tibiofibular ligament. I just totally saw the talofibular ligament, which, you know, the anterior drawer test tests the talofibular ligament, but it's not the talofibular, it's the tibiofibular. So this is a high ankle sprain. So you can rule out anterior drawer test, you can rule out the Taylor tilt test. The Thompson test is unrelated. We're talking about the Achilles tendon rupture, leaving you only with external rotation, or what's called the Kliger test. This is where you twist the ankle, you twist the talus inside of the mortise to pull apart the tibia and the fibula. And so the image looks something like this, the Kliger external rotation test. You stabilize the tibia, and then you rotate the talus inside of the mortise so that it causes a spreading to occur between, or a stress to occur between the tibia and the fibula. So you could have gone at this with the process of elimination, say, well, tibiofibular, that's certainly not anterior drawer, that's the ATFL. Taylor tilt test, again, testing for calcaneofibular or deltoid ligament. And finally, Thompson test is unrelated. So you could probably rule that one out, this one out, and this one out, leaving you with the correct answer, the external rotation Kliger test. So kind of a nasty question because it forces you to see what's going on. All right. I've got a bunch of other questions queued up. I'm going to go ahead and skip some of these because I want to, let's go ahead and I want to show you what the demo exam on FSBPT looks like so you can see some video questions. So while I'm queuing that up, Haley asks a question, how can we access this recording later? So I will be posting these recordings to the VIP course pages. As far as the other ways to access it, you can find us over on our YouTube channel. Should be able to find most of the videos I've got. Yeah, you should be able to find a bunch of the recordings there. But for sure in the VIP course dashboard, you'll be able to scroll down and see all these webinar recordings. All right, so let's go ahead and while I'm gonna skip ahead. Like I said, I queued up a lot of questions so you could see what it is we'll be talking about. So I'm not to the conclusion yet. Stand by. So you're going to see my beautiful face here for a moment. All right, so now I'm going to share the screen. What we're doing is we're going over to the FSBPT website. So we're going to share this guy. All right. All right, could someone in the chat box just confirm for me, can you see what looks like the FSBPT website? If I could just get a little confirmation. All right, so if you just do Google search for FSBPT demo exam, you'll find this NPTE demonstration examination. So what you do is you come here, it gives you the answers, like it shows you everything, but I wanted to show it to you. We won't go through all of it. I wanted you to see what it looks like though. And so this is a demo exam. As you go through the demo, you have to accept their terms. It's just like what it'll be on test day. These are the terms you'll see. The sections are different. This is divided obviously in a small sections. And so we're just going to go ahead and start the test. And so the first section is dedicated to the PTA exam. And so these are PTA style questions. I think we usually get a handful of PTAs who are joining us. Anyway, so I'll just mention this briefly about the PTA exam. So let's go ahead and go to the last, I think it's the last question in each of these. So this is an example of a video question that could show up on the test. And so as I like to say, you'll be underwhelmed by the videos. You'll say, "Oh, that's a video. It looks like someone shot it on their phone or something." And so the exercise in the video would be most appropriate for a patient who has which of the following gait deviations. So before we watch the video, we're going to look at the gait deviations. So contralateral pelvic drop during stance, so Trendelenburg gait, forward trunk lean during stance, circumduction during swing phase, and excessive lateral rotation during swing phase. So now we're going to go to our video. I'm going to go ahead and set it to loop, and we'll watch this video. Can someone name this exercise? What do you call this exercise? What would you name this exercise? So yeah, we always call these monster walks or side steps with TheraBand around the knees, but monster walks are such a fun way to describe it. All right, so now we have to say which gait deviation would be corrected with this exercise. Well, this is clearly targeting the hip abductors. So therefore, the correct answer is that contralateral pelvic drop during stance phase, so a Trendelenburg gait, in the case that you had a weakness of the abductors. So again, you see 5-second video, no sound, just a very simple video. All right, we're going to go ahead and advance to now the PT questions. All right, this is what it looks like. You have a scheduled break if you want during your demo exam. All right, so now let's go ahead and I'll leave the rest of these to you so you can go through those individually. This is an example of an image question. Do you want to do the image question right now, or should we focus on video questions? What would you like to do? This is a pick your own adventure. Image or video, or image and video? Got some votes to do both, so let's go ahead and do it. I will, assuming you can see this well enough, I'm going to give you a chance to select an answer here. I will be quiet and let you read it, and then we'll talk about it. So I'll give you about a little less than a minute. I'll be quiet while you read it, and then we'll talk about it together. Ready, set, and go. All right, so this is an example of reading an image question, and almost always I suggest you read it backwards, meaning get an idea. While abducting the shoulder, the patient in the photograph denies pain in A, but reports increasing pain in B. Which of the following disorder is most likely present? So now we're looking at our disorders. We're going to see AC joint, subacromial bursitis, infraspinatus tendinopathy, and partial tear of the supraspinatus. So now now that we've narrowed our vision here for a moment, we're going to go now to the images, and we see that this is what special test is being demonstrated in these images. What special test? So this is a two-step question. Number one, you have to identify what special test is being demonstrated, and then number two, what the interpretation of it is. So what is this special test? Well, this is called the painful arc test. The painful arc test, where if you had pain in range A, that would indicate subacromial bursitis. However, if you have pain in range B, at the top of the range of motion, this is really adduction. You're bringing the arm closer to the body, horizontal adduction. So you're smashing the AC joint. So that's the clearest test for the AC joint pathology, is to have the horizontal adduction. And so therefore, the correct answer here is that acromioclavicular joint lesion, because you have pain in B and not A. If you had pain in A and not B, then it would be subacromial bursitis. However, infraspinatus tendinopathy and supraspinatus, partial tear, and subacromial bursitis, they're very related. So you can see that they would, it would be hard to distinguish exactly, but you would know that subacromial bursitis would be the best there. All right, and then the final question. This is, again, a video question. Patient reports a decrease in pain when the physical therapist performs the test in the video. Based on the result, which of the following exercises should the therapist recommend? So we have a special test going to be shown to us, And we'll read through the answer options, and this one's tricky. So we'll just go through it together. With the patient in standing position, elbow 90 degrees flexion, the patient performs shoulder abduction while maintaining the back against the wall. We always call these wall angels. So like a snow angel on the ground, this would be a wall angel where you're keeping the shoulders pinned back and abducting through the range. With the patient in standing position, the patient laterally rotates the arm using a resistance band. So it'd be external rotation with resistance band. With the patient in prone position and the shoulder in 90 degrees abduction, the patient lifts the arm with the thumb pointed up. We call these prone T's. And then finally, with the patient in standing position, the patient elevates the arm overhead in the scapular plane. So just overhead in the scapular plane. All right, so now that we've identified our answer options, I will show you the video. We'll put it on loop. Again, you'll see that it's not much of a question, or not much of a video. I'll be quiet while you analyze that. All right, does anyone recall the special test that's being demonstrated in this video? This is called the scapular assistance test. This is actually only one half of the scapular assistance test. The first half is the patient performs it solo. The second half, they assist, and in this case, they describe a reduction of symptoms. Patient reports a decrease in pain when the therapist performs the test. So we see a reduction in symptoms that would indicate a scapular dyskinesia issue, meaning that the therapist helps, it makes it better. So they clearly have scapular dyskinesia, something's going on with the scapula. So the only answer option that will correct dyskinesia or poor coordination of the scapula would be answer 1. The wall angels, where they have the shoulder or the elbow flex 90 and you're doing abduction while maintaining the back against the wall. So keeping your shoulders retracted and abducted, that'll increase or improve the coordination in the scapula during upward rotation. So again, these other ones like the prone T, like it's not bad, but it's not working on dyskinesia or coordination. Rather, that's just a strengthening task. This one's more of the coordination task. This one's unrelated, the external rotation against the resistance band. That's a rotator cuff intervention. And then 4, this is the first part of this test. Elevate the arm overhead in the scapular plane. That's why they put it here, is that's when they have worsened symptoms. So you wouldn't want to have them just do what hurts. You'd want to do some intervention that would assist them. So there you go. That is an example of a couple of video questions that you could see on test day related to, again, a classic example would be special tests, interventions. There'll be 5 seconds or so, no sound. You can watch them as many times as you want. And it is what it is. It's underwhelming, I guess I'll say, underwhelming. All right. So with that, let's go ahead. We'll bounce back here to our slide deck. All right, so tell me, what questions do you have? Let me go ahead and share this screen so we can see. All right, what questions do you have as we come to a conclusion here today? So a question comes across over in the Q&A box. I'm a 3rd test taker this coming April. Which program do you recommend? Well, certainly if you're on a multiple attempt, I've got to recommend the VIP program, just because it's the one that stays, you consistently go through content, organized fashion. We dissect out practice questions. We lay the whole grid out for you. And that's where we see, like I just got a text message this morning. Somebody who just passed in January. They had a 75-point increase. So let me see. They had previously posted 547. What was it? They posted 547. I don't have it pulled up right here, but again, classic example. They saw a significant increase because they were organized and they got to know the content and apply it to test questions. So I'd highly recommend that. Again, I recognize money doesn't grow on trees, but for the quantity, like if we just did the number of hours as tutoring, it would be like at least double this. And so this is for the number of hours you get and the quantity of content, you just can't match it. Again, I know there's other courses that charge like 4 times what I charge for this sort of a thing. And it pains my soul to see people do that, just because you can get about double the content at 1/4 the price. Let's see. Question comes across. Sush says, I scored 595 on my 3rd attempt. Any suggestions on how to go forward? Yeah. So 595s, any of you in the top 590s and the top 500s, I think it's clear that you have good content mastery of a lot of things, but really the goal should not be to improve by 5 points, but to improve by 50 or 105 points. The reason is that you've got to blast past that 600 mark. And really the ways to do that, there's 2 things. You have to have more content mastery and then application of that content. And that comes with repetition and practice. It takes, what is it? I mentioned this on Tuesday, but depending on which study you look at, somewhere between 3 and 7 times to see something before you remember it, and about 30 times before it'll stick permanently. That's why, like, one recommendation I saw was that you, like, when you meet someone new, consciously say their name 30 times, and then it'll tend to stick a little bit better. Question says, is there a place where I can see the options for courses that are offered? So go to courses.ptfinalexam.com. So that's very simple, courses.ptfinalexam.com, or you can go to ptfinalexam.com and hit all courses. It'll take you where you can see everything that we've got. Let's see, another question. I'm a 3rd-time test taker. Should I take the test this year or next year? Or more like, would I have more chances of passing, keeping in mind the new changes in 2024? That's a good question, because the evil you know versus the evil you don't. Every time they update the exam outline, they make the passing mark a little bit harder. So for instance, the last big update was in 2018. They increased the passing standard, so you had to score about 3 to 4 more questions correct in order to pass. I anticipate they'll do that. They haven't made a specific announcement about that, but I anticipate that you will have to score a little bit better. And that's partly because as a PT practice, we have more responsibility delegated to us, more education involved. Like, it just, I would recommend sooner than later, because, and then there's other advantages there too, that it's not likely, but easy to forget things between now and next year. And so if you're like me, like, I'd be tempted, you wouldn't do this, but I would probably take a 6-month mental break, forget everything, and then have to restart. So highly recommend doing that. Ben says, what program fits me? Because I'm working full-time. Yeah, so full-time work, I understand everyone's got full-time responsibilities, whether with family, work, whatever. I do record everything as a part of the VIP class, so you can participate afterward. And again, that's where you get the one-on-one calls. You can get access to the full library. Again, I'd probably still push you this direction, recognizing that you'd probably not participate with us on a lot of our live stuff, but you would be able to catch some of it, especially right after. See, Anna says, I scored a 592 on my 3rd attempt after taking the PTA crash course. Would you recommend the PTA premium before I retest in July? Yeah, so yeah, the PTA premiums, those of you who are PTAs, I run a PTA premium class, and that's run by PTAs. It's specifically for PTAs and the PTA exam. And yeah, that PTA class, it ends up being about 9 weeks, because you get 6 weeks of PTA premium plus 3 weeks of crash course, takes you right up till test day. So yeah, definitely recommend that. Rachel says, do you offer any short-term reviews? So yeah, 3 weeks before every test day, I run a crash course. So it's just 3 weeks before every test day. So in this case, we'll start the first Monday of April. And the first Monday of April, we will start up and we'll go through the big 3 systems, cardio, muscular, and neuro, one more time. And it's just meant to be very brief, very quick review, usually a larger group setting. So we can't answer as many questions, obviously, because of larger group, but yeah, that's our short-term review, would be our crash course. And that's priced at $199. And so if you get a group of 5 or more students from your PT class, that it comes down to $99, but requires the group. Excellent. Great questions, everyone. Really great questions. See, a question comes across. I just joined the VIP course and I want to make sure I get the most benefit and am prepared for each live session. Should I just go through the MSK videos before next Tuesday and be prepared to discuss? Yes. So those of you who are part of the VIP class, here's your assignment. So between now and the end of MSK week, which is next week, you will have reviewed all of the videos, the study modules. So there's two things to review. There's there's 4 videos about study strategies that go into more depth about long-term memory aids, mnemonic devices, flashcards. It really guides you through how to make your studies very effective. So by next week, you'll need to have completed those study strategy modules, plus you'll have completed the MSK modules. So there's a bunch of MSK videos. And then ideally, the other assignment you have is to survey the MSK section of the workbook. Try to find your weakest areas and then fill in the workbook in your own words. Again, it's a way to stay organized and active as you go through the learning process, but you'll have surveyed the MSK section of the workbook. So that's between today and the end of next week. You'll have gone through all the MSK content. We will meet twice again as a part of the VIP class. We'll meet twice again next week for MSK questions. We'll do a lot of MSK practice questions and take your questions as well. And then just a reminder that I've got a bunch of the practice exams available. We just rolled out our 6th exam. The workbook is provided to you in PDF format. If you need a printed copy, just send me a quick email, will@ptfinalexam.com, and I can get a printed copy on the way. And then there is if you have an iPhone or some sort of iOS system, you can download the Teachable app. Teachable, that's the learning management system I use. Just Teachable, log into your Teachable account, and you're on your way. You'll look at it and you'll be like, well, this isn't much of an app. This is just accessing the course on a mobile device. So nothing too fancy. And it says, how much is a printed copy of the workbook? It's $35 to get it printed and shipped to you. So again, that's just basically my costs to get it to you. Yeah, $35 for the print and ship on the workbook. Excellent. And then as a part of the VIP course, you get complimentary access to the crash course. So yes, complimentary access. Ben says, do you schedule the live reviews in the afternoon? Yes, they'll be at this same time. So at the 3 p.m. Eastern time slot is when we have our live sessions. So just like today, just like you're here today, this will be how it is on Tuesdays and Thursdays going forward. Excellent. Great questions, by the way. Really good questions. Yeah, so the recording for today's session, I will post that to the VIP course page. Also, be sure to check out the YouTube page our YouTube channel, PT Final Exam. You can find us over there. Be sure to join us over on Facebook as well. We've got a Facebook group that's quite robust. I think you'll enjoy that. Facebook, Instagram, YouTube, that's where most of our presence is. The podcast, can't forget the podcast. And yeah, any other questions for me as we come to a conclusion today? Again, very much appreciate the effort you put into this. I appreciate you taking the time to hang out with me. And yeah, it's a big process, but it's worth it. You know that it's worth it. It's a pain. It doesn't take away the pain of the exercise here, but it's something worth doing and you can do it. Question says, what does the crash course provide? The crash course is just a very brief review of musculoskeletal, neuro, and cardio. So we go through a bunch of content in all of those, but very quickly. It's very much drinking from a fire hose. So we don't really take a lot of questions during that, just because we have so much to talk about, like talk about the nerves, talk about cranial nerves, talk about special tests, talk about interventions, but all in a very quick format. In the VIP class, we get a chance to go through that in a little slower format, and then again as a part of the crash course. Excellent. Okay, so with that, Anna says, would you please post this on YouTube? Yeah, so check out our YouTube channel. You'll be able to find most of the stuff. I should be able to get this over there. But yeah, certainly you'll be able to find all this content on the VIP course dashboard. Excellent. All right, so with that, we'll bring today to a conclusion. Again, very much appreciate you. I know that it's a tough process, but Will Crane fist bumps. You got this. You got this. And yeah. Those of you in the VIP class, I'll catch you again on Tuesday. In the meantime, stay safe out there. Happy studying, and I will catch you in the next one. Thanks, guys.